Hello, I'm the retired Professor of Neonatal Medicine from the Women's Hospital in Melbourne. And what I'd like to talk to you today is about the future of resuscitation, which is going to be monitoring what we do during resuscitation. So first of all, why do we need a monitor? You might think that all the things you're doing are perfectly acceptable. But the fact is that the assessments that you're making during the resuscitation are very largely subjective. From research, it's been well shown that clinicians really can't accurately assess tidal volume, and particularly the mask leak, which can be very large. We're taught that we should look at chest rise to gather how much we're ventilating the baby, but it's been shown that clinicians are very bad at assessing the degree of chest rise. We don't know what inflation and exhalation time we're giving. Very difficult for us to assess whether the baby's breathing and whether that's in synchrony with the ventilator. We know that unless you use end-tidal CO2 detector, clinicians really don't know whether they've intubated the trachea or not for several minutes. We can't assess airway obstruction. We don't know anything about alveolar ventilation. And oxygen and heart rate changes are done subjectively unless you happen to have a heart rate monitor. So the nice thing about having a monitor is that you can record what's happening, and that's very useful for debriefing and very useful for training. If you're just using monitoring during training, the first thing you've got to know is that you must have a leak-free mannequin to practice on. And many mannequins have a built-in leak, so you need to assess that and make sure you've got one that doesn't leak. But once you've got that, during mask ventilation, the trainees can immediately see from the monitor how much mask leak they've got. And then they can adjust their mask hold, make sure they've got good chin lift, and minimize the leak. Once they've minimized the leak, which can be done easily once you can see what's happening to the volume of gas in the leak, then the next thing is to be sure that you're squeezing the bag properly or adjusting the pressure on a T-piece device. Now, most people squeeze the bag too hard, and squeezing a resuscitation bag should only need 1 or 2 fingers. You're trying to get in a tidal volume of roughly 5 mils per kilo. So even for a term baby, that's only 15 mils. And adjusting the pressure might seem easy, but it's surprising how people can't think about adjusting the pressure to get the tidal volume. And the monitor then shows you what's happening and how well you're succeeding or not. Inflation and expiration times. People ventilate too fast a lot of the time, particularly their inflation time is too short, and with a monitor you can see what's happening there with tidal volume. Once you've monitored during training, then you can use that to accredit mask ventilation skills. And it's been shown during training that with a monitor you can significantly reduce mask leak and improve the way the baby's being ventilated. During a resuscitation, monitoring helps the team in many ways. It's similar to the training, but they can see exactly what's happening and adjust the mask leak, how much they're squeezing the bag, their times. They can see if the baby's breathing now and whether it's breathing in synchrony with their ventilation or not. Whether there's airway obstruction, sometimes you can't work out why the baby's not improving, and it's because there's obstruction. Expired CO2 also ensures that the baby is being ventilated, and sometimes you can have a good tidal volume, good rate, good everything else, but the baby's not picking up because the gas exchange isn't adequate and you need a slightly higher tidal volume. And although heart rate is the key to seeing whether resuscitation's being effective, what's really needed is absolute dynamic changes. A set heart rate, whether it's above or below 100, isn't important. It's whether it's actually changing that you want to know. And of course, we need to know what the oxygenation is, and then we can adjust the inspired oxygen. So if you do physiological recordings and a video, that is very useful for feedback and training. So here is one recording of a small baby being ventilated with a neopuff. And what this shows is that they were going at 120 a minute, whereas they thought they were going 40. They were not keeping their finger on the hole of the neopuff in order to produce a plateau pressure. But down the bottom you can see that there is a 90% leak round the mask. And so no wonder the baby wasn't getting better, and no wonder that they were panicking. And if they'd been able to see this recording and they'd been taught to recognise, they would have improved their resuscitation. So in summary, resuscitation of a baby at birth at the moment is one of the most difficult things in neonatology, and it's almost all subjective. The future is going to be, just like in the nursery when you're ventilating, that if you can see a display of the ventilation and all those other things, it gives the staff confidence about what's happening and empowers them to improve the resuscitation. This is not new. There are now over 40 papers describing monitoring during transition and resuscitation. We can't manage without monitoring in the neonatal unit, and the future's got to be we should use monitoring in the delivery room. Thank you very much.